Hello, good morning everybody. Today we are going to talk about breast conservation surgery. For this we have Dr. Geeta, who is a senior breast oncosurgeon with Max Patparganj as well as Vaishali. Dr. Geeta, welcome.
Thank you, sir. Thank you so much, sir.
As you all know that nowadays it is one of the most commonly performed surgical procedure for breast cancer. So I will be asking to you, Dr. Geeta, what are the indications of breast conserving surgery at the moment?
So, sir, the whole concept of breast conservation, you just as you have mentioned in one of our previous lectures, how mastectomy was the norm till the 1960s, when the trials of breast conservation versus mastectomy started happening, and then that is the NSABP 06 trial, and then Dr. Veronesi in Italy started doing the Milan 1, 2 and 3 trials to understand how it compares with mastectomy, what were the margins, and what was the benefit of adding radiation to breast conservation surgery. So let us start by just talking about what the goals of breast conservation are. It is good to be conservative, but not at the expense of oncological safety. So obviously the goals of breast conservation are to provide a survival which is equivalent to a mastectomy, and to have an acceptable rate of local recurrence, and also cosmetic outcome which is acceptable to the patient and also to the surgeon who does it. So when you ask about indications and contraindications of breast conservation, now we realize that the indications have actually expanded.
That's right.
There was a time when there were a lot of things that would not be subjected to breast conservation. Suppose you had a central quadrant tumor, you would not perform a breast conservation. If there is multifocal disease, you would not. And some multicentric tumors also. Even today for multicentric, we are not very keen on doing breast conservation. But in some select situations, you can actually do it even in those who are multicentric. But let me just come back to what are the contraindications.
So just for interruption, any size of the tumor is a contraindication for BCS indication, size of the tumor? Is there any cutoff range you like to?
So if you look at most of the trials, they look at tumors which are less than 4 centimeters.
That is what I.
But now with neoadjuvant chemotherapy, you can actually make a 5 or a 6, make it 2 or a 3.
That will be a different discussion probably, but by and large you take 4 centimeters.
Yeah, 4 centimeters.
And breast tumor ratio.
And of course breast tumor ratio, very right. You could have a 5 centimeter tumor in a patient who is a 44B or a 44C or even a 40C. In that situation, you can offer her breast conservation surgery. So if you look at absolute contraindications, which was a long list, but now you have only 4 things on the contraindication list, which is if during pregnancy you're planning radiation, you would not do breast conservative surgery. If it is inflammatory breast carcinoma, you would not. If it is extensive microcalcifications, as you see on a mammogram, you would not. And while you're doing surgery, you've done one margin, your pathologist says positive, you send another margin, still says positive, I think then you should stop and say, well, I'm going to go ahead and do a mastectomy. So there are certain relative contraindications.
I'll just ask one thing. Many of the students, they ask if the BRCA1-2 positive, if it has been done. Of course, we know that routinely it is not done. Is it a relative or absolute contraindication for BCS?
So BRCA1 and 2 is not a contraindication to breast conservative surgery, and you can do radiation also in those patients. Right. So it is not a contraindication. But if you want to do a risk reduction, obviously breast conservation will not.
Don't you think it is a paradox?
It is a paradox. It is a paradox.
For prevention, we are suggesting prophylactic bilateral, and for that you can do a breast conserving surgery. So how these two things?
So the thing is, it is all about choice. If my patient says, I'm a BRCA1, is it okay for me to do a breast conservation? I would say yes. But then the conversation for a prophylactic mastectomy will be very different. It has to be in her mind that she wants that risk reduction. Incidentally, only yesterday I've seen a patient who's a BRCA1 carrier, huge family history of breast cancer, had breast cancer on one side which was locally advanced. When she came for surgery, I said, let's do a prophylactic surgery. She refused. And yesterday she's come back with a lump in the contralateral breast. So there are these things. Eventually, whatever you decide.
But at present, BRCA1-2 is not a contraindication.
Not a contraindication. Not a contraindication. So then there are other relative contraindications like collagen vascular diseases, because we thought that radiation would increase the morbidity in the breast. But now with the techniques that they use in radiation, that is also off the contraindication table. Multiple gross tumors, like I said, it is a relative contraindication, but not an absolute contraindication. Separate quadrants, you can remove them with margins, and the radiation oncologist is happy to radiate 2 separate tumor beds also. If somebody's had radiation earlier on, that was also an absolute contraindication earlier, especially when they had mantle radiation for lymphoma. But now with the techniques being so good, there is no such contraindication to that also. And like you mentioned, the most important thing being a breast size tumor ratio. If you've got a 32 size breast with a 4 centimeter lump, you will still not offer breast conservation.
Maybe better by reconstruction rather than.
Yes, absolutely. Yes.
So, so you mean to say that all the women at present scenario is a good place, every radiotherapy facilities are available, early breast cancer, particularly less than 4, should be offered breast conserving treatment, an option, pros and cons of versus mastectomy should be, and of course patient should be taken into his wishes that whether she wants it or not. If yes, then this is the choice, first choice for treatment option. Right. So how do you, what type of pre-operative workup is required for patient to whom you are decided or it is a candidate for, and patient is also willing that this patient is for breast conserving surgery?
So one of the things is the imaging should be in order.
Okay.
So you have to understand the extent of disease. So like I said, if there is extensive microcalcification, you obviously won't offer it at all.
Mammogram after history, physical examination, mammography.
Yes, physical examination, mammogram, and maybe an ultrasound to understand what is the status of the lymph nodes. Is there any other lesion which is not picked up on mammogram?
For here you said lymph nodes. Positive clinical examination axilla, tumor is let us say 3 centimeter, but on clinical examination it is a lymph node which is likely to be malignant. Will it be a contraindication for BCS?
No.
No, it is not.
Node positivity is not a contraindication for breast conservation. But now there are a lot of things that have changed about how you treat.
That is different.
That is not a contraindication. But otherwise it is not a contraindication.
Okay, that is what I wanted.
Yes.
Because sometime in examination, the student face this problem that so positive clinical breast, clinical axilla is not a contraindication for BCS if tumor size is permitting this.
Absolutely.
Okay, so workup you said, history physical examination, mammography for multicentricity or other tumor in other breast or diffuse microcalcification. If it is not there, then this candidate. Do you think any patient before breast conserving require MRI of the breast?
So in young patients, especially the ones who've got dense breast, so mammogram will not give you all the information. If it is a 35, 40-year-old, her breasts are dense, and what you're feeling and you're seeing on the mammogram may not be the entire thing. There could be multicentric disease hiding in that dense breast. Okay. For that evaluation, you may be served better with an MRI.
But not routinely?
Not routinely.
Because sometimes, somewhere I've read that if you do MRI routinely, it decreases the rate of breast conserving surgery. It overdiagnose or overstate.
It does. So we are all guilty of that, because what happens is you see multicentric disease or there will be non-mass-like enhancement on MRI, which may actually not be disease, but the apprehension gets the better of you, and then you land up doing more mastectomies than
that is what.
breast
so
conservation.
Routinely MRI is not, it is mammography unless there is a specific indication.
That's right.
Okay. Any other workup of this patient, particularly?
So now, we would subject all patients to a biopsy before doing surgery, and we would also do an immunohistochemistry panel.
Okay.
So while I say that 4 centimeter is amenable to breast conservation, but now what has happened is the biology of the disease will also determine which kind of surgery you would do.
So what is
a HER2 positive or a triple negative breast cancer, even if she is node negative, anything more than 2 centimeters, they say you should go for a neoadjuvant treatment before you subject the patient to breast conservation.
It is accepted, or it is just a
No, it is accepted, because what is the idea behind this is, pathological complete response will translate into better survival outcomes.
That is what is
so for that reason.
That
but if you are ER/PR positive, HER2 negative with a lymph node also, I would be more inclined to go ahead with surgery first, because they don't respond as well to chemotherapy as the other subsets I said. Because you get a pathological complete response only in about 15% of patients who are ER/PR positive and HER2 negative.
So clinically positive axilla, along with biopsy of the tumor, you will do a ultrasound guided FNAC from the axillary node also.
Because
if they are positive, it will obviate the need of sentinel node biopsy.
Absolutely.
So you will be doing that. Okay,
That's
so
right.
any positive axilla along with core biopsy of the breast lump, it should be ultrasound guided. FNAC positive is of value, negative of course we'll talk about this.
That's right. So,
Alright.
so we'll talk about, like we've already talked about the size, the density of the breast. All this will influence your decision on what kind of surgery you're planning to do. And with oncoplasty, things will change again, but we will just stick to conventional breast conservation surgery. And of course, like you said, patient preference at the end of it will decide everything. You cannot force a patient to undergo breast conservation surgery if she's not comfortable with the idea. And if there is somebody who's asking for it, you must definitely offer it.
Another thing we have already talked, pre-operative planning, you said history, physical examination, mammography, and in a given case if required, ultrasound, or it is sonomammography by and large now, and MRI in a given case.
MRI in a given situation.
And you said after biopsy you will be going for immunohistochemistry also for HER2 and triple negative, particularly you said these candidate may be for neoadjuvant chemotherapy.
Treatment, that's right.
Alright, so once you have done, what are the different type of breast conserving? Like we have heard about quadrantectomy, then lumpectomy, somebody used tumorectomy. So what is the preferred means accepted terminology for BCS which the student should be answering with? Everybody should be doing that.
So I would say a wide local excision
is the
terminology. So now then we have to come to margins then. So we started off with the quadrantectomy is the term that Veronese used. So it was called quad meaning you're doing quadrantectomy and radiation. So that is, but it was like removing the entire quadrant for a small
cosmetically
tumor.
It was not
viable. So wide local excision, I'll come to how margins have changed and how incisions, how would you place an incision with better understanding of the disease. Earlier what we used to do, suppose that is the tumor. If that's the tumor, we would place an incision right there.
That's right.
There is no other, and especially, so now this is reserved only for those tumors where it is putting on the skin or is involving the skin. So you would not do this, suppose that is the tumor. If that's the tumor, I would place an ellipse of skin, take an ellipse on the...
So here I will ask another question is that, so involvement of the skin is not a contraindication again?
No, it is not.
It's not.
It is not.
Okay.
So involvement of skin is not a contraindication. If it is involved, you would take the skin along.
Okay.
And tethering of skin, like we all know, does not change the stage. So you can do this conservative surgery, but you just have to...
But if ulcer is there?
Ulcer will make it T4B.
Make T4B.
So we will not.
Okay.
So this is only tethering. If it is tethering, then you just have to remove the skin on top of this thing. You will not approach it from anywhere else. But suppose your tumor is not, it's somewhere here, and the skin is not involved, you can do incisions from elsewhere also. So let me just show you. It could be from the inframammary crease.